Hello, and thank you so much for allowing me to be a part of your rehabilitation conference. My name is Kali Dayton. I am a nurse practitioner in the United States, and I am thrilled to be talking about Awake and Walking ICUs, which is true mastery of the ABCDEF bundle. I do have the following disclosures. I am the CEO of Dayton ICU Consulting, and I have financial relationships with these companies, which will have very little or nothing to do with the following presentation. Now let's talk about Awake and Walking ICUs. To preface, my first job into critical care medicine was as a nurse in 2012. In my interview with the nurse manager, she said, "Hi, how are you?" And the very first question was, "Would you be willing to walk intubated patients on ventilators?" And I had no idea what that really meant, but I was so new, but I said, "Yes, of course, absolutely, I would love to." And then I started working in that ICU, and they really did treat walking intubated patients just as normal, routine, and optional as giving an antibiotic. Now, I want you to just look at these images and pay attention to how you feel. What were some of the first feelings that ever hit you when you saw these images? Raise your hand if this looks totally normal to you. If you didn't even blink an eye at seeing patients awake, eyes open, even out of bed and walking. Raise your hand if this was shocking to you. If this elicited feelings of alarm, concern, surprise, that's okay. That is normal, because what is normal in critical care medicine is not having patients awake and mobile, but having them sedated and immobilized. So to be able to talk about Awake and Walking ICUs and to dive deep into the ABCDF bundle, we must first acknowledge that sedation and immobility are what most of us in critical care medicine have ever known. We are all a product of our training and our experiences. We practice what we know. So why is automatic sedation and immobility so normal? To understand why we are where we're at in critical care medicine, we have to understand where we came from. In the 1970s, medically induced comas were not normal. They didn't even really exist. Patients that were intubated were usually awake and mobile. But we have to understand that those patients were not the kind of patients we see in our ICUs today. If they reached the level of acuity and critical illness that we see today, they would not have survived. So these patients were not as sick, but yet, even with the endotracheal tube and mechanical ventilation, they were awake and mobile. But in the 1990s, we started to experiment with how to treat patients with ARDS. And we thought that in order to inflate stiff lungs, we needed to give large volumes and high pressures. So we were giving 12 milliliters per kilogram of tidal volumes for ARDS, which is 2 and 3 times the volume that we give now today during lung protective strategies. And we had old archaic ventilators and stiff endotracheal tubes. So considering this process of care, it was impossible for patients to be awake and synchronizing with the ventilator. So that's when we started to bring up medications from the operating room, such as benzodiazepines, barbiturates, propofol, opioids, paralytics, and we started to sedate them for not just a few hours like in the OR, but for days, 2 weeks. And we noticed that they synchronized better with the ventilator, they oxygenated better, and better yet, their eyes were closed and they were holding still. And we started to believe that they were sleeping. We didn't have the research in the 1990s like we have now into the 2020s to understand the severe risks and harms associated with giving patients sedation for days to weeks. But when we started to do these things, a lot of myths and misinformation was instilled into the culture and the fiber of critical care medicine. So we're going to address a few of those. One of the first myths is sedation is sleep. It is very common for critical care clinicians to believe that patients are as comfortable and peaceful as they look. Their eyes are closed, they're not moving, so they must be sleeping. And to sleep is better than to be aware of what is going on in the ICU, to feel the lines and drapes and tubes. So if we sedate them, then they are sleeping and they are unaware, and we are protecting them from trauma and harm. That is a myth. What we have to understand is what patients are actually experiencing in the ICU under sedation. We have to hear it from survivors like this one.
They were terrible. The delirium, and I'm sure that was from those strong drugs. I was laying there and I couldn't move, and I felt like I was pinned down, but I knew I was in the hospital bed, and I could see babies floating all around me, and there was a fire around me, and I couldn't help these babies, and it was the most terrifying feeling in the world to be laying there. There's a fire, and I'm worried about these babies. I can't get to them, and they're going to die. And it was horrible. I mean, it was traumatic.
The facts are
they were terrible.
that sedation is not sleep. Sedation disrupts the brain activity so severely that it causes sleep deprivation. And when that occurs, patients are at high risk of developing ICU delirium, which can oftentimes lead them to have alternative realities that I don't even like to call hallucinations or nightmares, because they are vivid and they are often graphic and real in nature. And we don't know what's going on inside of their minds from our side of the bed. But patients are oftentimes experiencing horrific delirium during continuous sedation. The next myth is that every intubated patient must be sedated when on mechanical ventilation, when in reality, we know that there are very few indications that require altered consciousness from sedation. For example, the times in which sedation will be indicated involve intracranial hypertension, status epilepticus, the inability to oxygenate with movement. Those are indications for sedation in which it's unavoidable. We must sedate patients. But otherwise, they may not have a real indication for sedation. And we have to hear it from those that have had it both ways. And they share how much better it is to be awake while intubated.
And I have it in my charts to never be sedated unless it is absolutely 100% necessary.
Wow.
No matter what. I am not afraid to be on a ventilator, but do not sedate me. It's do not sedate me. The sedation is what I'm afraid of.
The next myth is that it is dangerous to mobilize patients during critical illness. This is a common fear that, understandably, is rampant throughout the ICU community because, one, we have not been trained to know how to mobilize patients. Two, we usually do not even try to mobilize patients until after they have developed delirium and or ICU-acquired weakness, in which now they are very exercise intolerant. They are confused, they are impulsive, they are very weak and deconditioned, there are fall risks. So we have to understand that mobility can be safe when we get the timing, the level, and the process correct to make it a safe procedure. Because in reality, when we look at the research, there's a meta-analysis that included over 14,000 mobility activities in the ICU, including intubated patients on mechanical ventilation, even with a PF ratio of 89. They found that early mobility has a 0.6% adverse event rate. So those adverse event rates include hypotension, hypertension, hypoxia, falls, unplanned extubations, things like that. And still, it was less than 1% in which those events occurred. But there are high risks that happen when we do not mobilize our patients. We increase the risk of mortality, needing a tracheostomy, PEG tube, increase the time of the ventilator-associated pneumonias, hospital-acquired infections, falls, delirium, increased length of stay, PICS. It is much more dangerous to lay in bed for most of our patients than it is to mobilize and get out of bed, especially early on. So we have to understand when we consider the risk versus benefits of how we manage patients on mechanical ventilation or even during critical illness in general, is that sedation and immobility lead to delirium and ICU-acquired weakness, which then results in a high risk of acute to chronic cognitive impairments, psychological deficits, and physical impairments. And this can lead to a post-ICU syndrome. So we can greatly impact our patients' chances of surviving the ICU, as well as what kind of lives they go on to lead after the ICU, by how we manage them through their sedation and mobility management. So let's look at specifically delirium. We know that patients with delirium have much worse cognitive impairments long after the ICU. They are at 120 times greater risk of long-term cognitive impairments, which can be at the same level of mild Alzheimer's and moderate traumatic brain injury. This can take away their ability to care for themselves, to return to their careers, to resume their family dynamics and relationships. This can be life-altering. So I would invite you to consider, if sedation causes delirium, we may be thinking about a sedation-induced brain injury. We also need to recognize that what happens during delirium, the horrors that they experience under sedation, can stay with them forever. 1/3 of delirium survivors have PT weeks after discharge. 1/5 still have it a year after discharge. And this is a life-altering and can be even a life-ending diagnosis. This can be panic attacks, depression, anxiety. This changes lives forever. I would invite you to scan this QR code to listen to survivors that have lived through it and continue to live through the impairments that they have suffered from PTSD. Now, many may say, well, that's really sad, Kaylee, but our patients are so sick, we have to sedate them. It's life or death. And sometimes that is true, right? If someone cannot oxygenate with movement, you may have to sedate them. But we need to also understand that we need to be considering the risks, even just with mortality. If all we care is about helping our patients survive, we have to understand that delirium doubles the risk of dying in the hospital. For every 1 day of delirium, there's a 10% increased risk of death. Even 6 months after discharge, their risk of dying is tripled compared to patients that did not develop delirium. So this is a life-threatening acute brain failure. This is an organ dysfunction, and it needs to be top priority. Now, we need to also look at what happens from sedation into immobility, which is ICU-acquired weakness. We first must understand that the muscular system is a vital organ for survival. It is connected with almost every other organ system in our bodies. And so when we cause our muscles to fail, we can greatly impact survival as well as the function of how are we going to get them extubated. We have to understand that breathing is not just the lungs, but it involves the respiratory muscles, which involves the abdominal muscles, the accessory respiratory muscles, as well as our cognition. So as we intubate patients, we need to think about keeping their muscles and their brains intact. While we treat the acute process in the lungs, we need to be keeping the rest of the body functional so that it can take over the work of breathing when the acute process is resolved. But when we lose this muscle mass during ICU-acquired weakness, we then greatly impair the ability to wean from the ventilator, successfully extubate, and especially walk out the doors to resume their normal lives. We need to be looking at the muscular system as a vital organ system for survival and a system that we must protect and preserve even early on in the ICU, just as important as the kidneys, especially during mechanical ventilation. We have to appreciate that when patients come to us into the ICU, their muscular system is already under attack. There are so many things that are happening that are causing muscular dysfunction and muscular atrophy, including cytokine production. We may have septic shock, stress, pain, trauma, things that are causing an inflammatory response, which then cause microvascular changes, metabolic derangements, electrical alterations that then change how the muscles function and cause them to quickly atrophy. And during this inflammatory response, these inflammatory markers are causing damage and atrophy to our muscles, which then incites more release of cytokines and inflammatory markers, which then produces a greater inflammatory response. So allowing our muscles to atrophy or expediting the atrophy of our muscles is really pouring petroleum onto this fire of inflammation, which exacerbates multi-organ dysfunction and results in greater brain injury and muscular atrophy. On top of everything that's happening during critical illness causing this muscular atrophy, we then implement interventions that greatly exacerbate this and expedite this muscular atrophy, such as prolonged bed rest. We need to understand that, especially with our geriatric patients who are already undergoing changes in their musculoskeletal system from aging, when we add in bed rest with hospitalization, we drastically expedite the muscle loss and dysfunction, which leads to many repercussions that will jeopardize their likelihood of surviving, especially the quality of life that they go on to live. We also need to understand that on top of the bed rest, we also are giving medications that are very toxic to our muscles. So let's talk about propofol in particular. We love propofol. We think it's short-acting, especially during procedures, not so much during critical illness necessarily, but it seems very benign, has a lower risk of delirium, and yet we fail to recognize the impact that it has on the muscles. One, it leads to absolute disuse. When we sedate our patients enough to chemically restrain them, they now are not even contracting a muscle. That quickly causes us to atrophy, even if we don't have critical illness occurring. Propofol also inhibits the GABA receptors. It disrupts the sodium channels in the skeletal muscle, which decreases muscle excitability. So we see even patients that come in young, strong, functional, healthy, that after a day or two of propofol, they're very sluggish. Cognitively, they're sluggish because their brain is disrupted, but also they lose fine motor skills, muscle control, strength, because they don't have the same muscle excitability. We also know that propofol is a mitochondrial toxin, so it is myotoxic. This is likely one of the reasons that propofol is an independent risk factor for diaphragm dysfunction. Even without mechanical ventilation, propofol can cause diaphragm dysfunction because it is a muscle and because propofol is toxic to the muscles. So we need to understand that when we do not combat the effects of this muscular atrophy and we implement bed rest, immobility, and sedation, our patients have high risks of ICU-acquired weakness, which results in diaphragm dysfunction, which makes it very hard to get off the ventilator. It increases mortality. It increases time in the ICU. It decreases return to work rates. It increases the workload for our team because it's a lot of work to be able to rehabilitate these patients. Now, this is a video from one of your ICUs, and I think this is just a beautiful video. I want you to watch.
No I teraz niech pan staje. Ostrożnie, no.
But I want you to also take note. I don't know anything about this patient, but my suspicions are that this was a patient that likely walked into the hospital. I'm not sure what they were diagnosed with or their course, but it seems to me that they had prolonged bed rest and potentially sedation. And now they are unable to wean from the ventilator. So now we have a tracheostomy. Clinician is doing the right thing and rehabilitating them, and they're using the equipment great. And this is really a great rehabilitative measure. Maybe this wasn't necessary. Maybe if we had preserved the muscular mass and function and the cognition to be able to mobilize far sooner, would they have become this weak, this atrophied? If we look at their legs, very low muscle mass, very high fall risk. It's going to take a long time for them to really rehabilitate. And they're at high risk of a ventilator-associated pneumonia, pressure injuries, lots of other secondary complications. So they have a long road ahead of them before they truly survive the ICU and be able to thrive. So then what if we focused more on preventing delirium and ICU-acquired weakness instead of treating it? There are going to be times when delirium and ICU-acquired weakness are unavoidable. We may have patients with severe status epilepticus, and they have to be sedated for prolonged periods of time, or some traumatic brain injuries in which they won't have the cognition to mobilize promptly. But we need to be questioning after each intubation on every patient, is there an actual indication for sedation? Do we have to set our patients up to have delirium and ICU-acquired weakness? Is early mobility just for rehabilitation on the back end, or can we use it on the front end of critical illness promptly in order to prevent these complications? We know that patients must be mobilized within 72 hours after intubation in order to have any impact on the development of post-ICU syndrome. When we receive our patients into the ICU, we need to be looking at this global perspective and looking at the two pathways that they may go down. If we intubate them and then automatically start sedation, they are likely to be immobilized, develop delirium, ICU-acquired weakness, ventilator dependence from diaphragm dysfunction, hospital-acquired infections, many complications that could result in their death. But if we don't sedate them, if they don't have an indication for sedation, can we then promptly mobilize them, prevent delirium, successfully extubate them, help them survive and have the quality of life that they lived before? And this leads us to the ABCDEF bundle. How do we keep patients on the right pathway early on in their ICU stay? Now, maybe some of you have heard of the ABCDEF bundle, maybe some of you have not. And even if you've heard about it, we're going to dive a little bit deeper because I think this bundle has been misinterpreted. We need to understand that the bundle is a toolbox and a pathway to help our patients survive and thrive. So A is for assess, prevent, and manage pain. I would suggest that A is best mastered when we have patients that are awake, communicative, and able to tell us what they're experiencing, what kind of pain they have, where they have it, if our interventions are helping with their pain management. It's hard to know what a patient is experiencing when they are comatose and they are unable to express their needs and pain. B is for both spontaneous awakening and breathing trials. Sometimes, because these both fall in the same letter, we've taken them as totally interdependent. Obviously, patients have to be awake to do their breathing trial, but we don't have to be doing a breathing trial in order to wake our patients up. The awakening trials should happen as soon as there's no longer an indication for sedation. So unless a patient has a very specific condition that absolutely requires sedation, such as I've said, intracranial hypertension, status epilepticus, the inability to oxygenate with movement, we need to be waking our patients up right away. If we use a paralytic to intubate them, paralysis and is an indication for sedation, but after that paralytic is metabolized an hour or two after intubation, we need to take sedation off and see what our patients need. Give them a tool, clipboard, whiteboard, a cell phone, something to help us understand what they need. If they're in pain, if they're confused, if they're scared, have the family at the bedside and help them stay awake. We do not want to be giving sedation unless there's an actual indication for sedation. It is going to be easier to take sedation off after intubation than to take it off days or weeks after intubation. Because once patients develop delirium, they're going to be very scared, agitated, traumatized, impulsive, confused. That's very hard to care for. And it's hard to keep someone from pulling out the endotracheal tube if they think it is a snake down their throat. So it's easier to get patients awake shortly after intubation. Those awakening trials should be happening as soon as there is no indication for sedation. And then we do the breathing trials when they're getting closer to being extubated. Once they hit certain ventilator parameters, now we're going to allow them to take their own spontaneous breaths on a spontaneous mode and see how they're doing and see if they're ready to be extubated. C is choice of analgesia and sedation. So this is questioning, do we have an indication for sedation? If we do have an indication for sedation, then we need to be looking at what's the safest sedative. We know that benzodiazepines carry the highest risk of delirium. They increase mortality. They are harder to metabolize out of the body. So we need to be looking at if we do have a need for sedation, such as, again, intracranial hypertension, seizures, do we have to be giving midazolam or can we give propofol? Can we get away with Precedex? Things that are lighter sedation, less deliriogenic, shorter acting. What is the safest option? And then looking at how do we give it at the lowest dose possible and then questioning each day, each shift, throughout each shift, is there still an indication or is it time to take it off? And D is delirium, assess, and prevent. Now, the only tools that we have to prevent delirium are real sleep, family engagement, mobility, and avoiding medications that cause delirium. But when we automatically sedate our patients after intubation, we take away their ability to get real sleep. Now they are sleep deprived. They can't go into REM cycle 3 and 4 if they have sedation going. They cannot mobilize. They cannot connect with their family. And we're giving medications that cause delirium. So we cannot practice the D of the bundle unless we allow patients to wake up as soon as possible and be free of sedation. And now we can implement these actual delirium preventative measures. And which leads us to E, early mobility. Having patients awake and mobile needed to happen within 12 hours after intubation in my awake and walking medical surgical ICU. Yet this oftentimes happened within hours after intubation. And it's not always walking around the halls, but it's oftentimes sitting up at the side of the bed, as long as they met inclusion criteria. There needs to be safety parameters, and each clinician in the ICU needs to have the skill set to critically think through, are they appropriate for mobility? Are they stabilized enough? Things like vasopressors or high ventilator settings are not necessarily exclusion criteria, but we need to be able to monitor our patients before and during and after mobility to make sure that they are safe for mobility. And then F is family engagement, having the family there, right there at their bedside, having them awake enough to hold their hands, look them in the eyes, write to them, answer their questions. That is what the ABCDF bundle is about. So instead of it just being a very systematic checklist, we need to see it as a toolbox. These are tools for a very specific purpose. And this is what most of the ICU community has missed. We've interpreted the bundle as an on and off switch for sedation just towards the end when we're trying to get them extubated. It's just a ventilator liberation bundle. But we need to see the bundle as an early intervention, early on, right after intubation, with the goal of keeping patients as awake, communicative, autonomous, and mobile as possible. This is a patient that has asthma. She has lots of chronic conditions, and she's had many intubations. And she came onto my podcast, and she shared that how awful it was to be intubated and sedated, to have delirium, to have to rehabilitate. She's in medical school. She's young. She's had a lot of chronic conditions, but she's strong. She rides horses, and yet 6 days of sedation, she couldn't walk. She lost her physical function. She was traumatized from delirium. So then the next times that she required intubation, she advocated to be awake. And she said it was so much better to just be able to be awake, telling people what she needed, being a part of her journey, being able to advocate for herself, and being able to be mobile. It made all the difference in her care. She'd much rather be awake than sedated. So awake, communicative, autonomous, and mobile. Those are words that I constantly drill into ICU teams to be the goal early on in ICU state, unless there is a contraindication. So we need to understand that the bundle is our pathway to reach the destination of an awake and walking ICU. And I define an awake and walking ICU as a team of any specialty, trauma, neuro, medical, in which they critically think through the risks of sedation and immobility for each patient. So they only give sedation when there is an indication for sedation. They then give the safest sedative at the lowest dose for the shortest duration possible. And patients are doing their highest level of mobility unless there is a contraindication to mobility. And there's open family visitation. They understand that families are a key part of the ICU team, and they don't just get kicked out at 7 o'clock at night. We would never kick out a physiotherapist or a nurse at 7 o'clock at night. We need to keep the family at the bedside, engaging and helping the patients as a key member of the team. So when we really apply this way of critical thinking and treating patients early on, it's much more likely and easier and safer to have patients awake and walking looking like this. If this patient had been sedated for 5, 7, 9+ days, it is not likely that she would still have the ability to walk. They are preserving her cognition and her muscle mass and function. We know that by walking, patients are mobilizing at the highest level of their mobility within 48 hours after intubation. They have a 20% improved cognition level 1 year after discharge. So we're not just preserving her ability to sit, stand, walk, swallow, use a toilet, write on a clipboard, advocate for herself, but we're also thinking through, this is protecting her brain. This is making it so that she can go back to caring for herself, working, living the life she lived before by doing this early on. And she's got a lot of drips. She probably has high ventilator settings. She's probably sick. But it's safer to do this now than to try to start standing her after she loses the ability to stand. This is safety in the ICU. So when we look at the ABCDF bundle, we can see throughout the ICU community, throughout the world, and even within each country, even within the United States, there's a spectrum of compliance. Some teams will tell me, yeah, we practice the ABCDF bundle, but really when I look at their practices, they're still automatically sedating their patients. It usually ends up being deep sedation, meaning patients don't really respond even to voice. And maybe they do some SATs, SBTs once ventilator settings are minimal, and now they're trying to extubate them. So I would say that was low compliance. Other teams maybe are still automatically sedating their patients, but maybe they do awakening and breathing trials every day. Maybe they turn the sedation off briefly, long enough to then put them on a spontaneous mode on the ventilator. But once they fail that, then they turn sedation back on, and that's it. But they check off the check boxes, right? Other teams might lightly sedate their patients. Maybe most of their patients are maybe a RASA -1 or -2. Maybe they kind of open their eyes to voice and make some eye contact. That's better And maybe they do awakening and breathing trials, but they still don't mobilize their patients. Patients are still not able to communicate and advocate for themselves, be autonomous, and especially not mobile. Other teams might not even sedate their patients, but they still have not quite mastered the early mobility piece. And other teams have their patients awake, doing the highest level of mobility that they can do, unless there's a contraindication. And that is full compliance with the bundle. That is an awake and walking ICU approach. But we look into a study that was published in 2019, which involved 68 different hospitals throughout the United States. And this was, I think, started in about 2016, where they took a few people from each hospital, sent them to Vanderbilt University in Tennessee in the United States, and they trained them for a few days. Then they sent them back to their hospitals and said, okay, now go teach your teams, which I think is a very big task, to suddenly take teams from automatic sedation and immobility to trying to be awake and moving. That's a huge endeavor. And so I think it's a lot to ask of a few people to get a little bit of training and then change things so drastically. So we see when they did this study that very few had 100% compliance. Only 8% of over 15,000 patients actually had all of the elements of the bundle. Only 12% were out of bed, standing, bearing weight. So I would say this is a fairly low-level compliance. They went from this red zone to this yellow-orange zone, right? So they made some improvements. They were giving less sedation, less benzodiazepines, moving patients a little bit more. But even with that little change, they still found that 7-day mortality decreased by 68%. Patients were 68% more likely to be alive in a week. Coma and delirium decreased by 25 to 50%. So they reduced acute brain failure by 50%. Physical restraint use decreased by over 60%. Mechanical ventilation decreased. ICU readmission decreased by 46%. Patients were 36% more likely to discharge home rather than to a care facility. And they found that outcomes were dose dependent. These numbers, though impressive, were the average within these 15,000 patients on a lower level of compliance. They found that the closer care got to an awake and walking approach, the less sedation patients received, the more they mobilized, the better all of these outcomes were. Coma, delirium, restraints, mechanical ventilation, death, discharge, readmission, all of these things got better the more they reached for the goal of having patients be awake, communicative, autonomous, and mobile. So what does this mean in practice? I want to share an example of a patient that I cared for in my awake and walking ICU. This was a story that no one really thought was a big deal. It was really normal there. This is the kind of care that we can provide when our teams are trained and know how to really practice the bundle. So Luke is a 22-year-old male with a history of trisomy 21 and autism. At baseline, he had a cognitive function of a 3 to 4-year-old. He was admitted for mycoplasma pneumonia and mild ARDS. He was intubated on assist control at a FiO2 of 80% and a PEEP of 12. So, understandably, there were a lot of questions that we had to ask. How do we keep Luke safe? Obviously, everyone wants to make sure that he has the pulmonary support he needs from the ventilator. We don't want him to self-extubate. But we had to expand that evaluation of safety beyond that. We had to ask, now, does Luke have an indication for sedation? Can he oxygenate with movement? We didn't know until we let him wake up and move on the ventilator. We had to ask how will delirium and ICU-acquired weakness impact his life? If he developed delirium and he developed a brain injury from his cognitive level of a 3 to 4-year-old, if we gave him more cognitive impairments, would he lose the ability to toilet himself, dress himself, feed himself, say the few words that he knew how to say? That would drastically change his life and his family dynamics. If he developed PTSD, would he stop being as affectionate and loving and communicative with his family as he was? If he developed ICU-acquired weakness, would he lose the ability to walk? Would he ever regain the ability to walk? Would he be able to be extubated? Could he breathe independently? Once the pneumonia was resolved, would he then need a tracheostomy? No, trachs are very normal in some ICUs, but they're not benign. They come with risks of stenosis, infection, bleeding, and just change the quality of life for many patients. So we had to really zoom out and say, how will our choices today, right after intubation, impact him tomorrow, next week, and for years to come? How can we keep Luke awake, communicative, autonomous, and mobile? So we zoomed out and we looked at, okay, we know that he's at high risk of delirium and ICU-acquired weakness and all the other repercussions, but how do we then cut that off? How do we keep him safe from delirium and ICU-acquired weakness? How do we put him on the right pathway that will make it so he's easier to care for, so that he's not impulsive and confused and weak and a fall risk? So we let him wake up. And we let his family be right there and hold his hand and make eye contact. And he didn't understand what was going on with the tube. Most adults can understand, but he could not. Nonetheless, we would give him his toys, his iPad, his music, his cartoons. Because of his autism, he slept in a tent at night. So we built a tent over his bed. We tried to humanize and normalize this very abnormal situation for him, and he was fine. He, at baseline, likes to cross his legs and rock back and forth when he's happy or when he's mad or anxious. So he got to do that. He got to rock back and forth and cross his legs, and he coped, and he was fine. This is what safety looked like for Luke.
Woohoo! Good job.
Around the corner.
Obviously, we had to be very careful with Luke. We didn't want him to fall. We didn't want him to self-extubate, but we also had to be equally, if not more afraid of delirium and ICU-acquired weakness for him. And when we shifted our fear and our concerns and our precautions towards preventing these two conditions, we kept Luke safe from falls, ICU-acquired weakness, death, infection, pressure injuries. All these things that happen to our patients in the ICU are prevented by shifting our fear towards these conditions. And that's how Luke was successfully extubated after 11 days. He had some baseline dysphagia, so he did go home with a feeding tube, but after a week it was out. And he was able to successfully walk home from the ICU and discharge home with his family and resumed his baseline quality of life. A week later, his mom said that he was back to being playful and happy and loving and his normal self. So how do we start? I know this information and seeing these images can be really overwhelming. Start by one patient at a time, one by one. Find a patient that is fairly routine. Maybe not your sickest ARDS septic shock patient, but maybe your simple pneumonia patient, COPD exacerbation, asthma exacerbation. Explain to them beforehand what the risks are of sedation and that you'd like to let them wake up and communicate right away so that you can keep them mobile and prevent all these complications. Let them wake up after intubation, give them pen and paper, adjust the ventilator, help them be comfortable, and let them be functional and start early. Mobilize them within those first 24 hours after intubation so that the team can see what it's like to have someone be calm, compliant, awake, communicative, oriented, and safe on the ventilator, and then even mobilizing early so that they can see that the patients can move their own bodies and do functional mobility. Sitting, standing, walking, we want to preserve those exercises. Teach your teams why and strategically implement the how. Develop safe patient handling skills, interdisciplinary collaboration, and family engagement. So when you look at what is an appropriate level of mobility to do, what's safe and what's not safe, that really can depend on the patient. What can they do at baseline? If they were not mobile at baseline, if they were in a wheelchair, they're not going to likely be walking in the ICU, but we want to focus on preserving their baseline functional level, as well as the things that will help preserve their respiratory muscles, such as sitting, standing, and walking. Those all engage the diaphragm and the accessory muscles that we need to breathe. So we need to be thinking about weaning from the ventilator right after intubation. Even though we may not be getting off the ventilator until a week later, we're thinking about preserving those muscles for it. Activities like staying supine in bed and using the leg bike or the arm bike has no proven benefit. Electrical stimulation has no proven benefit. What we know works is actual functional mobility, sitting, standing, walking early on an ICU stay to prevent muscular atrophy and loss of function. I know the bundle is really overwhelming. All these letters can seem like so much that sometimes teams think, we'll just start with one at a time, one letter. We're going to start with just awakening trials. But it's really hard to have patients awake on the ventilator with this thing strapped onto their face and this very abnormal, these ventilation settings and things like that without mobilizing them. Mobility is a key part of keeping them calm, compliant, preventing and treating anxiety and agitation. We need to be mobilizing to prevent delirium. If they develop delirium, it's really hard to keep them awake on the ventilator. So we need to understand that all these letters are very codependent. We need family. We need the mobility. We need to be doing awakening trials promptly. We need to be avoiding sedation in order to make sure all of this can work together. But again, just start with that one patient and start it early, not after delirium and ice-acquired weakness have happened, but before it happens. And that's when you're going to find your greatest success and find that it takes less people, less time, less resources to make this happen. I invite you to listen to this episode with Dr. Makita Fuchida. He went and visited my ICU to see it for himself after he had heard the podcast. And after he had walked through this ICU, spent a few days there, seeing patients sitting up in the chairs, reading the newspaper, watching movies, texting their family members, he went back to his ICU and he tried it out. And he said that he was so nervous to let this patient wake up. He'd explained to her, this is the very patient he did it first with, explained to her what was going on, that it was going to be uncomfortable, that he was going to be there, that she was going to be able to talk with her family member. And he said that when she was starting to wake up, he was shaking. He was so nervous. And she opened her eyes, looked at him, smiled, and gave a thumbs up. So I invite you to listen to this podcast episode in which he shares his journey as a physician leading these changes in his ICU. I would also invite you to read this recent publication where it shares a lot of the history of awake and walking ICUs, a lot of the research, dive into the citations. There are lots of implementation suggestions within it. This is a great place to start. And keep a humanized perspective of this. There's a lot of science behind it, but in the end, it's allowing our patients to be themselves during critical illness so that they can be themselves after critical illness.
Okay, ready? Back and forth.
How are you gonna do it if you really don't want to dance?
You trust her? And go. Fine, girl. Get those hands up.
Get your back up off the wall.
Your big hug, my love. I can't finish it. Are you gonna twerk too? Oh my God, I love you, baby. Look at me and Megan. I'm like, whoa.
What you gonna do?
My cheeks. Oh my God. Oh my God. I
Got to get on the groove.
Don't get me started.
And I'm happy to answer any questions about that.